Today on Diagnosing Health Care, we're celebrating our 50th episode. And to mark the occasion, we're looking at how the past 50 years of healthcare will impact the future of healthcare in the next 50 years. Hello and welcome. I'm your host, Nivedita Patel, an attorney in Epstein Becker Green's healthcare and life sciences practices based out of our Washington, D.C. office. When Epstein Becker Green was founded 50 years ago, the U.S. healthcare system was just beginning to tackle solutions to the core problem. How can the U.S. manage healthcare spending while providing access to high-quality healthcare products and services? Although there's been progress over the past 50 years, the industry continues to be challenged by the same fundamental question. As our firm marks our golden anniversary, we're looking to the next 50 years serving the healthcare and life sciences industries as they continue to navigate these same issues. On today's show, we're going to talk about the past, present, and future solutions to that fundamental question. How can the U.S. manage healthcare spending while continuing to provide access to high-quality healthcare products and services? If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. Joining our discussion today are three veterans of the healthcare field. Mark Lutes. Mark is chair of the board of directors of Epstein Becker Green. Mark joined the firm in 1984. Under Mark's direction, healthcare compliance attorneys, reimbursement consultants, engineers, and scientists review the nuanced regulatory concerns of the healthcare industry. Hi, Mark, and welcome.
Good morning. Nice to be with you.
We also have with us Lynn Shapiro Snyder. Lynn is a senior member of the firm and has also served on our board of directors. Since 1979, Lynn has helped EBG's healthcare clients successfully serve their communities and protect their investments. She's the founder of WBL, the Women Business Leaders of the U.S. Healthcare Industry Foundation. Hi, Lynn. Thanks for joining us today.
Good morning, and thank you for having me on this very special 50th episode.
And our third guest is Ted Kennedy Jr. Ted has been a member of the firm for nearly 10 years and has a focus on healthcare policy. He is an active leader in the movement to expand opportunities for individuals with disabilities, has been a healthcare regulatory attorney for more than 2 decades, and has served the public as a former Connecticut state senator. Hi, Ted.
Hi, how do you do? Thank you. It's been a privilege and an honor to practice law with such an amazing group of attorneys. And thank you for inviting me to be a part of this special podcast of Diagnosing Health Care.
Great, thank you. So to get us started, we want to kind of set the stage with a discussion of what the real fundamental question is here. Over the last 5 decades, the U.S. health spending as a share of the economy has increased dramatically. So in 1970, the U.S. spent about 6% of its GDP on healthcare, as opposed to 2020, where the U.S. spent 19% of the GDP on healthcare consumption. So over the past 50 years, we've tripled healthcare spending as a percentage of the U.S. GDP. Mark, aside from acute factors like COVID-19 and 2020, what are your thoughts on why U.S. healthcare spending continues to increase at such a dramatic rate?
That's an excellent question. I think it goes back to the fundamental paradigm for both our government program spending and our ERISA plan spending. In each case, the plans cover whatever is, quote, medically necessary to diagnose or treat a medical condition, assuming that it's within the scope of standards of conventional practice. Judges are ultimately very reluctant to find that new diagnostics or therapies are experimental and should be excluded from coverage. And so, as a consequence, there will be additional expenditures. A Duke professor called this situation, in legal terms, a, quote, failure of contract. That professor was a fellow by the name of Clark Haverhurst, who developed that thesis of the failure of contracts, meaning the ERISA plans and the government health plans' failure to specify particular therapies that they were willing to cover. And he developed that seminal analysis when he was on sabbatical from Duke and working with us at Epstein Becker some 30 years ago. But that observation, I believe, rings true for us today. We have a history of employer plans commercial insurance and government healthcare programs that have all committed to cover whatever is medically necessary. And that creates very strong financial incentives for the development of new therapies and the maintenance of care patterns that are not inherently cost sensitive. With this ingenuity and the human desire to help others with medical conditions, and employers' inherent desire to want to attract and retain employees by providing good care, I think it's a little wonder that the percentage of GDP devoted to healthcare is substantial and will continue to grow.
Mark, I would agree with you. And I would also suggest that we've all been the beneficiaries of that medical necessity coverage because the longevity of people in our lifetime has grown because of the innovations that have occurred with the advent of Medicare in particular. And the baby boomers and older people having two generations on Medicare is something that suggests that we're going to be a greater percentage GDP, even if we are more efficient. It just is.
Great point.
Ted, what are your thoughts on the issue of the healthcare spending in the U.S.?
Well, Mark mentioned both the incentives of the ERISA plans, the self-funded plans, and of course government spending. But when you look at the support that Medicare has, and the fact that we are now at 10,000 Americans a day are turning 65, and the fact that those voters 65 and older are the most active political participants in terms of voting, it's no wonder that representatives in Congress on both sides of the aisle are listening to what their constituents want, and that is a strong Medicare program that now is obviously growing in ever increasing size each passing day.
And Ted, you make a great point. We saw that confirmed just in the last couple of months with the passage of the Inflation Reduction Act, which expanded the Part D coverage available and protected consumers even more from costs. So the political will continues to be expansion of coverage to meet that political demand.
We have the question. It's clear this is an age-old question within the U.S. Trying to manage healthcare spending and providing high quality care at the same time. But over the past 50 years, there have been a lot of unique and interesting ways to attempt to solve or address this issue. Different solutions have come and gone based on public policy or kind of what the creative solution is at the time. Lynn, is one of the attorneys who's been at EBG since the firm's early days, what would you say has been EBG's legacy in connection with the U.S. tackling this problem that Mark laid out for us over the past 50 years?
Well, when Stephen Epstein founded the firm in 1973, the Medicare and Medicaid programs were less than 10 years old. Can you imagine that? And health insurance was predominantly indemnity. There was no such thing as PPOs or UROs or any kind of care coordination or even prior authorizations. Our audience might not know this, but our roots stem from helping to implement the Federal HMO Act, which was enacted in 73. Ted's father, Senator Ted Kennedy, was the principal sponsor. Richard Nixon was the president coming from California. He was familiar with these entities. The Department of Health, Education, and Welfare engaged EBG to help create a state regulatory framework for model acts so that entrepreneurs could create these entities depending on grant and loan money. And when that program ended, we ended up converting many of them from nonprofit to for-profit so that they could continue to get access to capital and continue to grow. Over all these years, first of all, they go by so quickly. What are some of the lessons learned? In my view, the private-public partnership that we have in the U.S. market is a very unique footprint. Outside the United States, many countries start with a fully public program. And yet, over time, these almost 50 years, I've seen those countries begin to put private sector initiatives in because the public sector alone cannot be efficient or provide the innovation. And here in the US, we started as a private initiative for health benefits, and the government stepped in those areas where our market was not working, such as for our senior citizens and our more indigent population. So where are we now? We have hybrids, some managed care, some choice. These tight integrated delivery systems cannot cover our entire country because we really have some very difficult supply side challenges. Not enough hospitals, not enough doctors. And we're all still trying to manage or coordinate care and shift or share risk. But we now have better access to data and technologies. What I'm seeing is that we're trying to spend the money on the right cohort within the covered lives to get the most out of perhaps what would be where we need to manage the care and where we don't. And most importantly, we're getting the patient more engaged than ever. There was a passivity about the patient years ago. And if we don't have a healthier population to begin with, we're always going to have a problem with costs. So diet, exercise, wellness benefits, all those types of things are critically important, and social determinants of health are also critically an important part of managing the costs and still providing care, whether it's Medicare, Medicaid, or commercial insurance.
Lynn, you make a couple of excellent points. Let me just go back to one of your initial ones, which relates to the mixed system, the public private system. Your point is excellent that if only one half of that system, the government funded system, is all in on value based purchasing, it won't be enough to get the response from the provider community that we need to make those efforts successful. So it calls to mind an opportunity potentially for the self-funded plans of this country, which still account for 60+% of the overall healthcare spending, to lean in on value-based purchasing and other innovations such as those that you listed to get the maximum effect in terms of system response.
Well, I just remember, Lynn, the days where, the concept of managed care, the words managed care, made many, many people nervous. But now, we talk about value based care. We talk about gain sharing and cost effectiveness and pay per performance. These are all different words for the same concept. And to your point, when Part D, when the Medicare drug benefit was being designed, you had many people in Washington, including many Democrats, who for years wanted to expand the Medicare program to include pharmaceuticals. You had many Republican members who distrusted the government provision of healthcare and insisted that any delivery model should be done through the private sector. And what do you have now? You have a Part D program that got what the Democrats wanted, which is more, pharmaceuticals, and many Republicans too obviously wanted seniors access to this benefit, but through a private healthcare delivery model. And you see this, for example, in Medicaid managed care throughout many of the states. Medicare Advantage is the fastest growing component of Medicare. So I do think you're going to see more of this hybrid model, healthcare delivery model, where you have the government funding, but overseen, managed, and cost controlled by a private sector model.
Interesting you mentioned Part D, Ted. When I started in Medicare at Epstein Becker, one of my first projects was Medicare managed care. And it's always bothered me a little bit that CMS is a bill paying organization, not always a consumer protection agency. And when it outsources to the private sector under Medicare Advantage, it has to use a different mentality in order to do what it needs to do. I've always thought they should be two separate agencies, because as long as Medicare is a bill payer and spends most of its employee time on that, the Medicare Advantage program doesn't always get the time and attention that it perhaps needs or deserves.
Lynn, what would you say? Ted mentioned that it's all the same solutions, just with different terms, and it's maybe the jargon of the decade or, flavor of the month. What would you say has really driven some of those changes to go from, one flavor of the month to the next? Is it just it's not successful for some reason, and so we need to come up with a creative way to repackage?
Well, I think it's as much technology driven. For example, years ago, we had something called a withhold in the contract. When a doctor ordered lab services or ancillary services, a certain amount of the payment was put in a withhold pool. That was done manually and through contract provisions. And at the end of the time period, we weren't quite sure who owed who money. And we would then renegotiate the participating provider contract. Now, with technology, we don't call it withhold, we call it risk sharing. But we're in a much better situation to be able to track the costs, to be able to see who really is ordering it. But it's still risk sharing. And provider risk sharing is a way of integrating payment with provision of service. It's a matter of whether you're fully integrated or partially integrated. And partial depends upon how much risk is being shifted to the provider side of the coverage equation.
It goes back to Lynn's point at the outset about the original vision of the HMO Act to incentivize providers to make the hard choices as to what is the most cost effective care path based on their training and view of the symptoms and the available clinical care paths. That was a fundamental tenet of the HMO model. As Ted points out, we call it different things today, but that tenet remains the same. I think as much as it is driven what Epstein Becker has done for the first 50 years of its existence, I think everyone on the phone would predict we'll be at that same problem for the next 50 years.
Agree.
So as we've talked about, some of the past solutions that the country has attempted to address the problem. I want to move on now to really talk about the future and what's going to happen in the next 50 years. So, first, we want to focus on life sciences innovation. Over the past decade, there's been significant advances in life sciences industries when it comes to gene and cell therapy and other biopharma innovations. Time to market, I would say, and production costs are really a priority in this area. Lynn, what are your thoughts on how the life sciences industry will or should view the cost benefit analysis of these types of innovations that are really like on the forefront right now?
I'm so glad you asked the question in life sciences. I'm very proud of the fact that although our roots come from managed care, it was back in the early 90s that we expanded our practice to include the life sciences part of the healthcare industry to be able to service their FDA as well as their coding coverage and payment needs. And I am a coding coverage and payment lawyer. I love working with the inventors. They need capital. Capital needs a return on investment, and there's tremendous competition for the premium dollars. We all need to be more sophisticated on whether some new invention is a high cost item or cost effective in the long run, or perhaps superior quality breakthrough, and regardless of whether the payer is the same payer year to year and whether the payer is government or private sector. The challenge is that we don't really have standards for how to do these analyses. So if a commercial company prepares that type of analysis, it's unclear whether the payer community is willing to accept the parameters of that. The other challenge we have is about coding coverage and payment pathways. Because of our diverse public-private partnership, the coding system, the coverage system, and even the payment system needs to be somewhat more predictable, and it's becoming more transparent. This is particularly important for new innovations in the area of personalized medicine and in digital health. And we need reliable data. And if life sciences is going to rely on positive outcomes, to get paid for their widget, then we all need to know that the data is reliable data. And we're fortunate to have had the electronic health record and the new data lakes that are occurring. And I'm very much looking forward to the way we use data to help companies bring new products to market quicker, faster, and with data that will convince the payers that it's a legitimate new invention to pay for.
Lynn, you said a lot there. I want to take a step back and unpack some of those comments that you made related to innovation in life sciences. So first, Mark, what are your thoughts on weighing this balance? There's going to be criticism that the U.S. spends a lot in life sciences innovation. The flip side of that is that in the long run, we invest the money up front. In the long run, there's going to be overall cost savings. What are your thoughts on
Well, I think Lynn does take us back to the same question that we were ruminating on at the outset that Professor Haverhurst noted, and that is, as she said, coverage standards are as a matter of consensus. As new therapies are available, there is incentive to adopt them. Again, to Lynn's point, that's not necessarily bad. Society may want to heavily invest in therapies for its citizens. We just have to acknowledge that those incentives are present and give room for countervailing processes, such as value based purchasing, to constrain the excesses. Because at some level, we're reliant on clinicians to make the right choice on a cost effective basis as to what's right for their patients. And so we need them incented to make a cost effective choice.
At Epstein Becker Green, I'm really proud to work with some of the leading healthcare innovators in the field of life sciences. And, you know, to me, this issue is personal. Some of you may know I'm a pediatric bone cancer survivor and amputee, and I credit my life. I was given 10% chance of survival in 1973, and but for medical innovation, I wouldn't be on the podcast here with you today. So I think we don't want to do anything to take our foot off the accelerator to ensure that America leads in the area of innovation and technological discovery. But we know that some of these costs, particularly these Me Too solutions, we just can't afford to continue to pay for that. So we're seeing much more now. For example, some people are concerned about the high cost, for example, of hepatitis C drugs, but for example, when you compare that to the overall cost of what it would previous cost to actually treat somebody with Hep C, it's actually a good deal. Many of these pharmaceutical solutions. So I think we're going to see much more implementation of value-based drug pricing. We know there are some examples right now, Lynn, right? With, for example, Aetna and Merck have a value-based drug pricing scheme with the product Januvia. So if Aetna covers Januvia and it doesn't meet certain A1C thresholds and blood sugar outcomes, Merck doesn't get paid. And we're going to, I think, see many more examples of that where insurers and others will pay for products if they actually do what they say they're going to do.
Ted, I totally agree with you. And I want to give a little shout out to CMS in two areas. In their coverage department, doing coverage with evidence development rather than say no. So it gives products, particularly medical devices, the opportunity to get coverage. And then if the data shows what they promised, they're allowed permanent coverage. And if it doesn't show what they promised, then CMS has a better leverage to say no later. And CMMI, the Center for Medicare and Medicaid Innovation, where multiple payers, Medicare, Medicaid, commercial insurance can come together to be able to help cover in a unique way a particular new invention. And I think here the public sector is leading on innovations around social determinants of health, but every ERISA plan has its opportunity to cover what it wants to cover. And I do think more and more ERISA plans are speaking up and doing things even ahead of government programs. And I'm looking forward to bringing many of these things to market with our clients because they're very innovative. And then we provide that innovation to the world, not just to the US market. And because we have multiple payers, if one says no, there's another door to go into to see if somebody might say yes.
Lynn, you mentioned personalized medicine, and I know that's something that's coming up here right now. Can you talk about how that may lead to some efficiencies or cost effectiveness?
Well, the personalized medicine is really similar to what I mentioned, which is finding the right cohort of patient who's going to benefit from the covered item or service. And personalized medicine is trying to zero in on, for example, which chemotherapy treatment is going to more likely work or do more damage than cure. And the ability to curate whether a piece of medical device going to someone's home is going to help them rather than to have step therapy, 30 days of no treatment, 30 days of less expensive treatment. If we can figure out with data which patient is the right patient to get the most out of that covered item or service, then we're spending the premium dollar more efficiently. And that's personalized medicine.
And I think that access to enhanced data is going to just help that drive
It's
that.
going to be critical.
So moving on from life sciences, I want to talk a little bit about care management. As we all know, the U.S. is just stepping into the much anticipated time frame where the baby boomers are aging. The U.S. Census Bureau is projecting that by 2030 is going to be a milestone year where the older adults in the U.S. will outnumber the children for the first time in U.S. history. Ted, how do you see this growing Medicare population impacting the healthcare? Obviously, it's going to be a large impact, but maybe you can break it down for us a little bit.
Obviously, as a longtime activist for individuals with disabilities, that includes obviously the largest cohort of individuals with disabilities are our senior citizens who face mobility, hearing, vision, other types of impairments and conditions. We need to be smart about how we deliver healthcare now. And we're seeing much more home based models, extending care models into the home, which is where people want to live. And it happens to be the cheapest place to provide care as well. So I'm very excited. You know, who would have thought that house calls from doctors that we all had when we were children would now be back and the most cost effective way to deliver healthcare? So we're also getting back to the prior comments about what is cost effective. It turns out that if you deliver hot meals to a senior citizen in their home, you're actually going to reduce their healthcare consumption and keep them out of a more costly healthcare setting. So we need to be creative and look at healthcare provision in a more holistic way.
Ted, that's a great example, and it does go back to the nature of the system that Lynn was telling us about. The fact that CMS is putting Medicare Advantage plans at risk and giving them funds, though, to do the innovations of the type that you just described, that's yielding real benefits to patients, to consumers, to Medicare beneficiaries. Question I would have is, can we get the self-funded plans to do likewise, to put some money on the table that give the providers incentives to create new care paths, new service delivery models of the type that you outline, and see what they bring to the advantage of their employees?
I would also add that our definition of health law is expanding because of social determinants of health. We're seeing IPAs that are not just doctors and clean labs and hospitals and ambulance companies, but it's also plumbers and carpenters and transportation companies and food service who are pivoting to provide those services to an industry that they're not sure what healthcare is. And our job as health lawyers is to help them navigate their new participation in what is a plus 50-year health regulatory scheme that they're not familiar with. And so the sooner and quicker we can bring in the providers of social determinants of health into the healthcare ecosystem, the sooner they can provide the goods and services that the payer and patient community are looking for in order to be more efficient and to have a better lifestyle, particularly for those people who are aging in place in their homes. We cannot afford to have everyone in nursing homes who are aging, and we really need to maximize that's where people want to be anyway, but we need to figure out better, quicker, how to help people age in place.
So when I think about it, I think about, the 80-20 rule that could be applied to many, many examples in our economic life. That is, 80% of the money in healthcare goes to less than 20% of plan participants. So, Mark, you talked about, can we get self-funded plans to make these same investments in value-based care as we're seeing in the Medicare program? But we know that that's not likely to happen if people are jumping around from job to job, from plan to plan. So one employer may make these investments and not recoup the benefit until many years down the line when that person may no longer be employed. So I think a lot of this innovation may take place in, for example, the labor union marketplace, or in these large states that have these retirees that are on the hook for paying for people's long-term care. That's where I think a lot of this innovation is going to take place.
And Lynn, as you mentioned, all of this is connected through data, right? So Ted, I completely agree and appreciate what you're saying, that healthcare is not just going to be doctors providing patients with care in a hospital. That's not what it's going to be anymore. It's expanding. It's car share rides. It's everything. It's grocery stores. And I think data is what's going to connect everybody. There's been a recent focus in U.S. policy to provide all the stakeholders in the entire healthcare ecosystem. And as again, we mentioned, this is really an expanding ecosystem with increased access to patient data. And the driving force behind that has been to, number one, empower patients to make more informed healthcare, and number two, to provide clinicians and other stakeholders with access to comprehensive information about an individual to both improve care coordination and ultimately improve the outcome. Some are saying, data is the new oil in the digital economy. And, we have EMRs in the past couple decades. We have health and fitness apps on your mobile devices. And we also have wearable devices. There's so much data out there. Mark, how do you see all of this increased focus on healthcare data, and how can it impact the next decade in healthcare? There's a lot of data. Somebody has to control it, regulate it, find a way to really harness it.
You raise a super interesting question. I do think data will help consumers shop more knowledgeably, arm them with better questions, but I think it does have its limits. That in healthcare, treatment choices are dependent on multiple variables and symptoms and what the feasible alternatives might be. Much of those are going to remain in a situation where the consumer really needs an informed clinician's guidance to make those choices. While there has been a theme that price transparency will lead to sufficient shopping by consumers that might constrain prices, even despite my antitrust training and experience, I'm relatively cautious in adopting that view, because while there may be some services that are sufficiently a shoppable service from consumers' perspective, many more aspects of treatment of chronic conditions are more nuanced and not susceptible to sort of commodity based shopping. In fact, I saw a paper by the Congressional Budget Office last week, which predicted that the transparency initiatives would only move the healthcare spending needle maybe a point or so. So it didn't put a lot of hope in that alone being the antidote to efficient spending. Now, there is one place where I think data is underappreciated, and I think Lynn alluded to it earlier, and that is that the data we now have as to patient conditions, beneficiary conditions, that feeds into risk adjustment being done by CMS, Medicaid programs, and some other programs has has given us the tools that we need to fairly share risk with provider groups and give the provider groups the financial incentives they need to help us make those very difficult decisions as to the most efficient care path for any condition presented.
Well, I think that data, this massive amount of unstructured data that is out there, is going to be complicated to try to make use of. I mean, think of the multi-billion-dollar companies and attempts to devote hundreds of the smartest people to try to figure out where are the nuggets of information in this data. But when I think, and again, I'm speaking to you is my experience perhaps as a former state legislator in Connecticut. When I think about data and how our society can better use data, I think there are some long term goals for which it's going to be very difficult to try to make sense of all this unstructured data. But there's some immediate benefits. For example, we know through many analyses that the hospital that you end up going to, for example, for chest pain, can vary by tens of thousands of dollars. So that's an area where I think better data can help people become much more cost effective and smarter consumers.
So I want to move us on now to where are we going to go from here, and maybe some of your predictions for the future. Ted, I'll go to you. Is the employer-based healthcare insurance system an individual small group market here to stay, or do you think we'll ever see a Medicare for all solution? And I know that's a very loaded question.
Well, I think it's fair to say that if we were beginning our healthcare insurance delivery provider delivery model today, we would not create the system that we have in place right now, where you have self-funded plans, people getting, as Mark said, 60% of Americans getting their health insurance through their employers, and everyone else more or less through the small markets or through government pay. So I think that probably Medicare for all. You saw many a movement maybe 5 or 10 years ago to actually raise the age of Medicare eligibility, saying that it's going to bankrupt the country. Well, in our last election, you had some leading candidates for president actually talking about lowering the age of Medicare, and that got a tremendous amount of political support. So what I predict is perhaps a hybrid, like in the Part D model, and you have more of a Medicare for all, perhaps, where you have the government participating in a program and the private sector actually administering the benefit, much as the same way they do through Medicare Advantage and through Part D. I don't know, but I think that whether it's the endless fee for service model um, cannot exist, and I think you have a surprising amount of agreement between Democrats and Republicans that we need to do more to advance value-based purchasing in our healthcare system.
I too don't see us moving away from our current pluralistic health system, having an employer based component to it, absent a change in the tax deductibility of healthcare benefits. I do expect, however, that the current portion of employer sponsored benefits may erode a bit, given the cost shift to employers as government, as it did in the Inflation Reduction Act, puts price caps on its own expenditures and leaves the self-fundeds more exposed to cost shifts. So that could cause us to see an increase in individual and family enrollment and government-backed options. Given the difficulties in bargaining in the sector, which we've spoken about earlier, the knowledge imbalance that is inherent in consumer behavior in the healthcare sector, I agree with my colleague that the primary cost lever will be what we today are calling value purchasing, both for the ERISA plan and government healthcare programs, each acting through managed care company intermediaries. Back before Congress took away the Cadillac tax limits on deductibility, I thought that it would make policy sense to align the programs on value based purchasing, to make exempt from a Cadillac tax those ERISA plan expenditures that would be made through a value based purchasing paradigm. We may yet have time to see those sorts of measures introduced to further incent the development of value purchasing that we're speaking about today.
I just want to make one more comment about that. When I give speeches about Medicare, I always ask the audience, how come chronic renal disease is covered by Medicare? It's a disease state. It's not a age or anything. And it has to do with the politics of that time. I do think I'm all about patient cohorts. When the government covers a population, it's both the insurer and the reinsurer. When the commercial market covers a patient, there's still a reinsurance market. I think that over time, the government is going to step in either as reinsurer or to identify patient populations where it is better for the federal government to be the payer or federal state share through Medicaid, because certain populations are predominantly Medicaid, certain populations are predominantly Medicare, but also there may be certain pockets of the commercial population that if we move them to the government payer side, we can make the commercial premium more affordable. I think the data is going to start to educate us which patient cohorts should be where. The other item I just want to mention is whether these exchanges really do grow and become stronger, like what Mark said, which is whether individuals will buy the health insurance because of either the fact that they're from small companies or because they want the flexibility not to be tied to their employer. And we'll have to wait and see if that infrastructure is there now, but we'll have to wait and see if people change their purchasing patterns around that.
This has been a really great discussion to see where the U.S. has been and consider where we're going as the country continues to balance the provision of healthcare with managing costs. As we close out the discussion, I want to ask each of you in 1 to 2 sentences, rapid fire, what is one prediction for what you think we will see in the next 50 years in the U.S. healthcare industry?
I'm not sure I can do 1 or 2 sentences rapid fire. After all, I am a lawyer. So I read biographies. I'm reading Louis Brandeis. He was a lawyer and a Supreme Court judge at the turn of the 20th century, before there was regulation like SEC, Federal Trade Commission, antitrust laws. He was instrumental in many of those new government entities and laws. I see the same thing happening with data. We will have a federal department of, I don't know the name, but it'll be data, privacy data, something around that. And what it will do is create that infrastructure that none of our current government entities currently have as a exclusive focus, in order to have what we want as a democracy, the way in which we want our data to be shared, to be protected, regardless of whether it's personal health information or just our personal information. And that's because HIPAA was not designed to be anything more than protecting personal health information in connection with an insurance transaction. And personal information is straddled over so many different state and federal laws. So I also am working on artificial intelligence tools, anticipating how the government's going to regulate them, And I'm helping clients create compliance programs around these tools. And I think this government agency, whatever it's going to be, is going to regulate the AI tools as well.
Great. Mark, what are your thoughts?
I'll go back to the last point that I was making. I think it's inevitable that at some point Congress will look at the current sort of bank check tax deductibility of healthcare benefits and say it's time to align the purchasing by plans with the value-based purchasing being done by the Medicare and Medicaid programs. And they'll look to that lever in some form, Cadillac tax or otherwise, to juice, to further incent the positive developments in the system that we've been talking about.
And Ted.
Well, I believe that the trends towards at-home care promise huge dividends and cost savings for our overall healthcare system. There were things that were done only in the hospital 5 years ago that now services can be delivered in the home. So I think the trick is going to be how to get Medicare, Medicaid, and commercial plans to reimburse accordingly for this care.
Great. Mark, Lynn, and Ted, thank you so much again for joining us for today's show. It was a pleasure having you all here.
It was a pleasure reminiscing with Ted and Lynn. As usual, had a great run for 50 years, and we're looking for many, many decades ahead of continuing to wrestle collectively with the evolution of a very complex but absolutely essential system for our country.
And thank you to all of our listeners. If you like what you heard, don't forget to subscribe. Diagnosing Healthcare is available wherever you get your podcasts.